Hello, I'm Karina Zapata, physical therapist and clinical research scientist at Scottish Rite for Children in Dallas, Texas, and I'm excited to provide key points of our manuscript entitled 6-Minute Walk Test Reference Values in Ambulatory Children with Myelomeningocele. The affected spinal level in spina bifida is associated with the ability to ambulate. Higher anatomical functional lesion level deficits have a lower chance of independent ambulation. Functional lesion levels include mid-lumbar for muscle activity at knee extensors, low lumbar for ankle dorsiflexors, and sacral for ankle plantar flexors. The myelomeningocele functional classification, or MMFC, includes MMFC2 for hip flexors and knee extensors, MMFC3 for hip abductors, and MMFC4 for ankle plantar flexors, and also considers assistive devices. The 6-minute walk test is a common functional measure of walking capacity. Although 6-minute walk test reference values exist in neurotypical youth pictured below, they do not exist for children with myelomeningocele. Understanding how expected 6-minute walk test scores specific to a child's age and spina bifida functional lesion level can help monitor a child's ambulation status, create functional goals, and help make decisions regarding various treatment interventions. Therefore, this study aims to determine baseline pediatric reference values of 6-minute walk test distance across spina bifida functional lesion levels. 2, to determine associations between 6-minute walk distance and 1 and 2-minute walk distances. And 3, assesses the impact of social determinants on 6-minute walk distances using insurance type and the Area Deprivation Index, or ADI, as proxies. The ADI ranks neighborhoods by socioeconomic disadvantage shown below. This prospective cohort study collected 6-minute walk distances of 145 ambulatory children with mid-lumbar, low lumbar, and sacral level myelomeningocele, and MMFC2, MMFC3, and MMFC4 between 6 and 18 years at a pediatric hospital. The distance walked after 1 and 2 minutes was also recorded. Mean 6-minute walk distance was shorter for myelomeningocele mid-lumbar versus low lumbar and low lumbar versus sacral lesion levels. This amounts to about 7 standard deviations lower than the age and sex matched mean from neurotypical youth, 5 standard deviations below the mean for the mid-lumbar group, and almost 4 standard deviations below the mean for the sacral group. Mean 6-minute walk distance was also shorter for MMFC2 versus MMFC3 versus MMFC4, and still comparatively low from the neurotypical mean. Mean 1 and 2-minute walk distances were strongly associated with the 6-minute walk distance. Children with public insurance and a high ADI, or Area Deprivation Index, walked significantly fewer meters than children with private insurance and a low ADI. So in conclusion, we determined reference 6-minute walk test scores across spina bifida functional lesion levels, which can guide intervention. Children with higher functional levels walked shorter distances than lower levels, and by MMFC group. Since the 1-minute and 2-minute walk tests were highly correlated with the 6-minute walk test, they may substitute the 6-minute walk test. Last, lower socioeconomic status was a social determinant in decreased walking capacity, which merits further study to maximize opportunities for activity. Thank you.